many countries, high income and low income countries, you need to integrate the policies, to take the issue of the policy into the mix of health systems discussion. And one significant event during this 1990s period was the publication of the World Development Report, titled Investing in Health. And this report actually established the fact that health is not just an expenditure, it's an investment, and there is a need for health systems strengthening, and so on and so forth. 1996 is also an important year in the 1990s, because at that time there was an ad hoc committee report on health policy and systems research and health policy and systems development. We will look at that report, excerpt from that report in the next slide. But this report and some work that took place during that time culminated the way for the establishment of a unit, or a specialized unit within the World Health Organization, called the Alliance for Health Policy and Systems Research. The year 2000 is also very important, because some people associate that year with the establishment of the field of health policy, and formally establishing. I mean, it's debatable. I know there are criticisms of that report as well, because it tried to compare the health systems, etc. But that report was kind of fundamental in the field of health policy and systems research, because it proposed a framework for health policy and or health systems. It proposed a framework for health systems. It tried to come up with some objectives of the health systems, etc. So it was a very seminal report, and really propelled this field of health policy and systems research. In 2004, there was the Mexico City Ministerial Summit. In 2008, there was the Bamako research, and in both of these conferences or summits, the issue of investment in health policy and systems research gained a lot of traction. And in 2010, it was actually a very, what should I say, like very important year too. The first global symposium on health systems research took place that year. I don't know, Josephine is here. I mean, we were kind of, what should I say, baptized in the field of health policy and systems research through an initiative called Emerging Voices. Um, One of the pioneers of that field at that conference was Tim Evans, who was my direct boss in Bangladesh at that time. I got interested about it since the inception of that conference. Many of you from Duke-NUS may know Shenglan Tang. Shenglan was also one of the members of the organizing committee who is still working here in the Singh Health Duke-NUS community. In 2012, the second health systems symposium took place in Beijing. Oh, sorry. In 2012 is also important, because they published another seminal report, the Changing Mindset report, which was actually the first WHO report specifically focusing on the health policy and systems research issues. And yeah, very important report. You can download it. It's freely available. In the same year, the second global symposium took place in Beijing, and also the Health Systems Global was established, which is still continuing. Every 2 year, they organize a health systems conference in different parts of the world, and the latest one happened in November 2024 in Nagasaki, Japan. Okay. Okay. So what is health policy and systems research? Sometimes this field is said to be the GPS of the health decision making. Okay. In this report, it's very aptly said to be the GPS. For example, it provides navigational support for the decision makers. It tells you your starting point, your problem. Okay. It helps you to set your desired destination, where you want to go. And also it provides you with the options of getting there. That is the different solutions that are there, okay? So what is health policy and systems research, or HPSR? HPSR seeks to understand and improve how societies organize themselves in achieving collective health goals, and how different actors interact in the policy and implementation. So it's not just about developing policies, about the implementation and the implementation processes also, that contribute to the outcome. So it's not about just measuring the outcomes. We try to understand the processes that are involved in the whole mix. By nature, I mean, it's very interdisciplinary. It involves multiple disciplines, such as economics, sociology, anthropology, political science, public health, epidemiology, that come together to draw a comprehensive picture of how health systems respond and adapt to the health policies, and how that policies can shape and be shaped by the health systems and the broader determinants of health. This field is distinguished by issues and questions considered. So the question is very important here, and it's not by the disciplinary base. Okay, so it's not just dominated by a particular discipline. Rather, it's more influenced by the questions that we want to answer or the problems that we want to solve. The research focused on the health services as well as the promotion of health. It is concerns for global and international issues as well as national and the subnational issues. It looks at the research on or off policy and addresses politics of the health systems and health services. It promotes work that explicitly seeks to influence policy. That's a very important characteristics, actually. It's not just a theoretical field that just understands certain phenomena. It tries to influence the policy also. It tries to speak truth to power. So what are the goals of health policy and systems research? So the goals are both research on describing a system, or that is to understand the system, and also this field poised to understanding and also changing the system as well, how the change happens and how we can actually change it. So HPSR seeks to understand what health systems are and how they operate, and what needs to be done to strengthen the health systems in order to improve the performance in terms of health gain and wider social values. So basically, this left side box is about evaluating the systems or evaluation of the current system performance, and our policies or interventions intended to improve the system's performance. So more about the systems. The right side box is more about the policy and processes. So how to influence the policy agendas to embrace actions to strengthen the health systems, and also how to develop and implement such actions in ways that enhance their chances of achieving the performance gains. Okay, so very action oriented evaluation of the policy processes and the policy making. And it's not just projection of the outcomes of this policy. Rather, we want to understand how the agenda is set, how the policies are developed, how the policies are implemented. This how question, why question, these are very murky questions, and we need to understand those questions and answer those questions through health policy and systems research. So it's very complex. This diagram sort of captures the scope of health policy and systems research. Okay, on one side, we have this whole health systems issues, and on the other hand, we have the health policy issues. And also, we try to understand the global and national contextual and political determinants and factors that influence health systems and health policies. So those are also part of the health policy and systems research. And when we talk about health systems, we do not just talk about the structures, infrastructure, organization, and financial resources, the technologies. We also talk about the software issues, the tangible softwares like the structures, the processes, and the systems, and also the intangible ones like the relationships between stakeholders, between patients and the doctors, the communication channels, the values and norms that drive a certain behavior. Okay. When we talk about the policy, we don't limit ourselves to the content or the instruments that written black and white policy papers. We try to understand different actors, their motivations, their power, their the political dynamics, We try to understand the ideas and interests of the institutions also. And eventually we try to change the policies and develop the health systems. So we talked about what health system is, sorry, health policy and systems research is, but it's important to understand what HPSR is not. It is not a clinical or basic science research. It's not only rooted in health economics and focus on health financing issues, although both of these are very important. But we need to understand that it's beyond just economic research or cost effectiveness and things like that. Is not focused on the disease distribution and causes of intervention, but rather we are interested in generic organizational social structures through which interventions are implemented. That's what we want to understand. We want to understand the processes. This diagram used by Hoffman 2012 in our WHO report helps us to understand where health policy and systems research fits within the broader health fields. So if you see, this is the I'm sorry, let me use okay, laser pointer. Okay, so basically, this is the health policy. This circle is about health policy research, and this circle is about the health systems research. And when we say health policy and systems research, we actually indicate this both of these circles. If you look closely, you realize that the sub-individual level biomedical research is not our field. We are not really biomedical researchers. But in the field of clinical and behavioral research, there are some overlap. Also, at the community level, population health research also has some areas of overlap with the health policy and systems research. Health systems research is again broken down into three groups, the micro, meso, and macro, which I will discuss a little bit about later with some examples. But when it comes to health service research, which is quite popular and very important in Singapore and many other countries, this is also kind of falls within the remit of health policy and systems research. As you can see, health service research includes service delivery science, improvement science, operation research, implementation science, which I do a lot as part of my role, management science, so on and so forth. But when we say health policy and systems research, it's not just micro and meso level. It's not just health service research. It's kind of plus. It's health service research plus. So it involves some macro level issues. For example, when there is a corruption in the Ministry of Health, perhaps a health service researcher may not be interested to address that question, but an HPSR researcher or health policy systems researcher is definitely interested to talk about corruption in the Ministry of Health, right? Or how, for example, the medicine is distributed from the ministry, from the higher level, from the district level to sub-district level. This is not within a hospital or a health service setting, but this is something that we might be interested in as health policy and systems researcher. We mentioned this term, health policy and sorry, health system and health policy a lot. So it's important that we kind of understand what is health system really and what is health policy. What do we mean by these terms? So health systems, according to the World Health Report, the seminal report that I mentioned, the World Health Report 2000, health system it means that it's all, or it kind of involves or includes all organizations, people, and the actions whose primary intent is to promote, restore, and maintain health. It's quite broad, actually. I mean, we don't have much time, but we could actually. I usually love to discuss about what you think is kind of part of the health system versus what is not. A traditional or typical mindset is that only things that happen within a hospital is health system. It's beyond that. Suppose a daughter-in-law is providing elderly care support um, to her grandfather. I mean, are we ready to accept it as a health system work? But according to this definition, it is, because its primary intention, or her primary intention, is to promote, restore, and maintain health, right? So these are some of the debates that were generated or started from this definition. There are many frameworks, uh, which are kind of very old frameworks, which are new frameworks. Control knob, the building block, which most of you already know. Systems thinking framework, dynamics framework, came from Josephine's work, actually. Um, okay, sorry. Yeah. So this is actually a very nice publication. You see the name Josephine van Olmen. She led this research and published this work. Helped me personally a lot to understand the field of health policy and systems research. She lined up different frameworks across time, how different frameworks, different researchers actually develop different frameworks. You see a lot of frameworks around 2000 to 2010 time and even afterwards. This was published in 2012. I'm sure there are several frameworks that came into existence even after these frameworks. Perhaps Josephine can talk about those frameworks too in future, or if you have time after my presentation. And we are also, Josephine joined as a very luckily, and she is here in Singapore now as a professor of health systems under Yong Lu Lin School of Medicine, and we're planning to organize a seminar if she has the time and interest. We will have a seminar maybe next month or in a couple of months, hopefully. We will learn more about the frameworks. So I'm not going into the frameworks. We will hear about these frameworks or other related issues from her. Um, Health policy. Health policy means the actions and also inaction that affects the institutions, organization, and services and funding of the health and healthcare system. Why I emphasize on action, in action, because there are many things that should happen but don't happen. So we need to understand whether these are deliberate decisions. Are these due to some vested interest that some policy should be there? A sugar control policy should be there. Salt control policy should be there, but it's not there. Is it because the people don't know, the decision makers don't know about its importance in the health, or their uh, their effect on health, or is it because of um, some commercial interests that preclude them from forming policies around um, sugar sweetened beverages or other harmful things like tobacco control, for example. So policy analysis is a very important field, or a very important type of research within HPSR. We try to understand factors influencing why and how the policies are initiated, developed, negotiated, communicated, implemented, and even evaluated. There are many frameworks that are used in policy analysis. We are currently doing a prospective policy analysis on healthier SG from the program evaluation unit. There are frameworks such as Walt and Gilson's policy analysis triangle, Kingdom's multiple streams framework, Schiffman and Smith's framework, and many more. Um, in my earlier slide, I talked a little bit about the levels of operation of the health policy and health systems, such as macro level policy, macro level health systems research, meso and micro. They're cross level. The next slide, in this slide, it's clearer. So macro level means the health policy and systems research that kind of incorporates the global and the national context. So more national level research on health policy and systems issues. The meso level research, health policy and systems research, is done at the institutional level, or or a local level in a district or a sub-district level. While micro level health systems research um, includes the individuals, such as the policy elites, the people who make the policies, or the managers, service providers, the citizens, or the patients. So there are some examples of both macro, meso, and micro level health policy and systems research. One good example of the macro level research is the work done by colleagues from the London School of Hygiene and Tropical Medicine, Dina Balabanova, and her team. They did a research on good health at low cost 25 years on. So initially study was done actually even earlier, but they did a follow-up of certain countries, some positive deviant countries, which achieved remarkable health gains or life expectancy gains despite their economic weaknesses or economic issues, economic problems. These countries, so they tried to understand using multiple methods. They followed up these countries for a long time. They tried to understand different aspects of the health systems, analyze the policy actors and processes, and tried to understand why, despite economic shortcomings, these countries succeeded in achieving health gains. So this is an example of the macro level health systems research. Next one is the meso level health systems research. So in Bangladesh, we tried to develop a comprehensive primary healthcare model based on our experiences from two sub-districts. So this research was led by two very well-known global health and health policy and systems researchers, Ron Labonte and David Sanders, late David Sanders, who passed away a few years ago. So we actually conducted a screening, secondary data analysis based screening to identify two sub-districts which performed, one sub-district performed the best and another actually performed not so good, actually. One of the worst performing sub-district in Bangladesh. And then we conducted in-depth interviews, observations in these health facilities, key informant interviews, household surveys, participatory rapid appraisal to understand why one Upazila health complex, despite the very similar type of setting, performed well versus another Upazila health complex or the sub-district level primary healthcare center, which did not perform well. What are the factors? What can we actually learn from these two sub-districts? So this is an example of meso-level health system because we are actually looking at the institutions located within a local level. It's not about the whole country. We are trying to understand two sub-districts. This is an example of a micro level health policy and systems research where it was actually my PhD thesis to understand the responsiveness of physicians in rural Bangladesh. Initially, we tried to understand through qualitative research, I tried to understand what is considered as responsiveness in the eyes of the service seekers as well as the service providers. And then we developed a measure, a psychometric scale to measure the responsiveness and try to understand why some physicians are responsive versus some others who are not. Since this research is on the individuals, service providers mostly, and perspective of the service seekers as well, it's more micro level health systems, health policy and systems research. So these are some of the typical HPSR topics, okay? For example, in the financial and human resources, we could try to understand different aspects of community-based financing and national health insurance schemes, human resources for health at the district level and below, human resources for health at the national level, the policies related to the human resources, why, what policy interventions are there to retain the human resources in the rural areas, and so on and so forth. There could be research on our HPSR research on organization and delivery of the health services. For example, research on the community involvement, equitable, effective, and efficient healthcare approaches to the organization of the health services, drug and diagnostic policies. There could be health policy and systems research on governance, stewardship, and knowledge management. Specifically on governance and accountability mechanisms, health information systems, the bottlenecks, or the issues related to information systems, priority settings, evidence-informed policy making, effective approaches for intersectoral engagement in health. Okay, these are some of the typical HPSR topics. Of course, it's not a exhaustive list. It's just an example of some health policy and systems research. One important area of discussion in health policy and systems research is the health systems strengthening. And this slide actually compares the health systems response against a disease-specific response and kind of answers to the question of systems strengthening. So when we are talking about systems strengthening, we are not really talking about only a particular disease or in a specific area. We are concerned about larger health systems response to certain health systems constraints. I won't read through all the examples. I'll pick 2 or 3 examples. So suppose there is financial inaccessibility, inability to pay, or there are informal payments. This is the constraint. So a disease-specific response would be how can we actually reduce the price for that particular disease, while a health systems response would be to develop a risk pooling mechanism or an overall health financing strategy, which will reduce the out-of-pocket expenditure. Okay, so you see the difference. It's not just about one particular disease. We're now talking about in the health systems response, we're talking about the overall health systems. I faced this challenge actually even today, just a few days ago, when I said that I work on health policy and health systems. The questioner, the person who was asking me, he was saying that, okay, on what disease you're working, what's your area of expertise, which disease you were working on? I need to say, okay, I'm not really expert in particular disease, but I work on the overall health system. I don't know whether I could convince that person or not, because the traditional mindset is that you work on a particular disease, you become an expert on tuberculosis and so on and so forth. Even during my own PhD research, when I was trying to understand the responsiveness of physicians, some of my PhD board members who were not particularly trained in health policy and systems research asked me to look at particular disease. For example, TB, tuberculosis is a prevalent disease in Bangladesh. He asked me to see how a service provider is responsive or not in providing tuberculosis treatment, which of course I didn't. I tried to look at the overall concept of responsiveness and how it plays out in a Bangladeshi rural context. So these examples perhaps can help you understand the perspective of a health policy and systems researcher and why they're so broad. Another example could be the physical inaccessibility, for example, distance to the health facility. A disease-specific response or a traditional or typical response could be to do some outreach programs to bring the services to the local community in relation to that particular disease. It could be tuberculosis, it could be onchocerciasis or whatever. On the other hand, the health systems response would be um, to develop a long-term plan for capital investment to actually address this issue of physical inaccessibility. We can even do research on multi-sectoral collaboration. How we can actually work with the transport department, for example, and how we can ensure that the services, the people can reach to the health facilities easily through a better mode of communication, better mode of transport, for example. Okay. Another example could be the inappropriately skilled staff or poorly motivated staff. So disease-specific response could be to train them on that particular disease, or provide them with some CMEs, the continuous medical education. But a health systems response would be to change the curriculum, to improve the curriculum so that the people have more skill set to address all the similar problems in that country related to multiple different diseases. So it's not just about one particular disease. So I'm skipping this slide because there are many examples. If we have time, we can discuss more, come back to these slides again. So now I'm shifting gear a little bit towards from the conceptual issues of health policy and systems research to more methodological considerations related to health policy and systems research. So health policy and systems research is not, a research of thought bubbles, it's more applied. It's not really something in your head that you feel good about understanding in depth. It's very, I'm not saying that's unimportant, but what I'm trying to say is that health policy and systems research is very applied. You need to change the system. It's very real world. It's not a laboratory based, or it's not really an ideal thing for armchair researchers. It's very much policy relevant. You need to consider the complexity in your research design. The investigator has little control over the events. There are many elements or many factors that are not within your control, and you need to address those things. You need to incorporate those things. You need to understand those phenomena. Um, there are different actors, and you need to understand different perspectives of the health managers, providers, patients, or even common citizens. There are social phenomena such as cultural issues, interests, leadership, politics, other contextual influences that you try to capture through your health policy and systems research. Um, so this is a causal loop diagram developed by some colleagues. A kind of a typical health policy and systems research. I mean, it's not the only type of health policy and systems research. This is just an example of the types of work health policy and systems researchers do. We are currently doing a similar work in Cambodia. Just started our clinical core at the Singh Health at Duke-NUS Global Health Institute, is helping the Cambodian allied health professionals to kind of understand their supply and demand side of the health workforce. I mean, the allied health professional workforce, and trying to develop a model to help them with the needs for such health workforce in their country. Is an example of a causal loop diagram, which we are designing for that project as well. This is from an old project from other colleagues. There is no single methodological gold standard in HPSR like RCT. We don't say that. We don't say that RCT is the best way to understand certain phenomena. So it depends on your research question. Okay, there are a range of study designs and strategies depending on the purpose or your research question. You do cross-sectional studies, longitudinal studies. Of course, those are the typical ones in epidemiology. But also, we do case studies, ethnography, action research, participatory rapid appraisal, and so on and so forth. And this can have more value than an RCT in certain contexts. I can't give an example on top of my head, but there are many situations where an ethnography can be very valuable, or case study can impart a lot of important messages for health policy. And also it embraces range of epistemologies. It's not limited to positivism, that is more quantitative approach to research. It embraces relativism and realism. Not going into that because it's not a methodology lecture and we don't have much time. Just the message is that it doesn't have any specific philosophical niche or philosophical priority. It depends on what you are trying to understand. Okay. So what makes a good health policy and systems research question? It needs to be substantively relevant. It needs to be worthwhile. It shouldn't be trivial, just questions for the sake of asking questions and just doing that. It needs to be worthy of the effort to be expanded. Plus, it needs to be clear, unambiguous, and easily understandable. At the same time, it needs to be, your research question should be specific, sufficiently specific to be clear about what constitutes an answer. It shouldn't be very ambiguous. It should be answerable. So can see what data are needed to answer it and how those data will be collected. So methodology should be very clear and interconnected. Okay, questions are related in some meaningful way, forming a coherent whole. So there could be multiple questions or specific research questions leading to general research question, but they need to be integrated. There is another way to look at what should be a good HPSR research question. It should be broad enough, beyond the disease and the treatment of focus, up above the program or service at the facility or the district level. It should be about the cross-cutting functions that underlie the service and program delivery. The system building blocks and interconnections among these building blocks should be somehow captured or addressed in your research in an ideal, in a good health policy and systems research. I have a few more slides, and I think we have some time for the questions. So I'll be brief. So there are some ethical challenges in HPSR. Suppose you are an observer and you have observed an unethical or a harmful practice in your health policy and systems. It's very common. I have experienced it through my research work. I have seen pilferage of medicine while people are dying due to the lack of medicine, due to shortage of medicine. But there are people who are stealing those medicines. Well, I was doing an kind of ethnographic research in Bangladesh. Should I speak up? Should I, what should I do? I mean, as a researcher, should I just observe it and just stay silent about it? Or should I actually tell the authority that this is happening? Well, I'm supposed to maintain their confidentiality. How to present finding in way that balance the confidentiality, but at the same time give voice to those people who are not usually heard. I mean, if you want to give voice to these people, there is a risk of exposing them to these powerful people who are making their life miserable. Um, Also, how to act in ways that have potential to stimulate the change. How can you address the unequal relationship between the people? So these are some of the ethical dilemmas or ethical challenges you face while conducting HPSR. There are some ethical principles to follow in general. It needs to be collaborative, not just for the sake of being collaborative, because collaboration um, usually gives you access to better research capacity, and also reduces the cost because you are basically collaborating with somebody at the local level. It helps in decolonization approach. You need to embrace the social values. You should not be limited by only the scientific value of your research. It has a social imperative, and that needs to be integrated in your research. Of course, you need to be scientifically, sorry, need to be scientifically valid questions. And of course, there should be fair selection of a study population. Um, there should be favorable risk-benefit ratio. There should be some independent review of your research. Okay. Informed consent should be taken, and respect for recruited participants as well as their communities. Okay. So sometimes this you need to think of whether you are getting consent from a group of people, but do they actually, do you need a larger consent? Do you need to make sure that your research actually reaches the community as well? So it's not individualistic field. It's very much related to the community. So you need to be careful of the ethical principles applicable at the community level or collective level, not just individual level. And this is my last slide. So there are a few other questions that come up in health policy and systems research. Who determines the questions? Is it you as an armchair researcher? I mean, sitting in your cozy room, or is it the people who you are interested to change the life of? There are issues of consent. Suppose you're asking for consent from a marginalized group of people. Are they giving you consent just because they want to participate in your research, or is it because they think that you are powerful, even though you're not really imposing it? But still, there could be perceptions that you're coming from a powerful group of people and they cannot say no to you. The issue of anonymity. Sometimes you cannot maintain the anonymity for the nature of research. For example, could be an observation-based ethnographic research, very difficult to obtain consent because everything that you see is basically coming into your research. Issue of a small sample size. Sometimes you don't get sufficient sample size just because there are not so many people to conduct, to get a good sample size for that particular research. Acting ethically towards the field workers. Very often we engage the community health workers, the poor community health workers, to collect data for you. Are they benefited from this? These people are usually overworked and under funded or under remunerated. and you are actually putting more load on them to collect data for you, for the data that's not really benefiting them. Is it, how can you be ethical? You act ethically towards them. Um, Also, you need to recognize the researcher's privilege and power. The data that you are getting may have some, I mean, may not be actually the reflection of the people. So suppose when I went to Bangladesh, I'm a doctor, I have a medical background. When I wanted to interview the informal care providers, they they had a lot of grievances against these powerful doctors and doctors community and so on and so forth. But since I represented a powerful group of people, they couldn't speak up. So I had to mask my identity actually. I had to go to a different village where they didn't know me. But the researcher's privilege and position of power actually interferes with the data. Gender is another issue that can come up, you know. Um, you're going to a Muslim majority country as a male person coming from Dhaka or coming from I don't know, from Jakarta or somewhere, interviewing some females. You may not expect to get proper information from them for on certain issues. And also the issue of generating social value for substantive relevance to where does a researcher's role end? Is it just after collecting the data and publishing article in Lancet Global Health, or you really have the imperative to change the system and really make a meaningful change in the lives of the people with whom data from whom actually helped you to gain your promotion and everything. So where do you stop? What's your stopping point? I don't know the answer, but I leave it as an open question and end my presentation here. Thank you for your patience. Thank you. Yeah, the floor is open for questions. Or comments or sharings that you have, even disagreements. If you think that what I say doesn't make sense, that's fine too. You can share your views.
Thank you, Taufique. We learned a lot from your presentation. So as we learned from your presentation that health policy and system research is kind of an interdisciplinary and have to need a better collaboration among the stakeholder and policymaker. So how we can start engaging with the policymaker from very scrap of the health policy and system research a question and development, and based on your experience, how you have been engaging and get a policymaker buy-in from the start.
So I think it's actually it's you need to actually invest a lot of time in that. It doesn't happen just overnight. You just go to a policymaker. You need to gain their trust and involve them. And this involvement with the policymaker should not be tokenistic. It needs to come from a genuine interest to engage with them, help them come up with, because they have their different perspective than the researchers, and you need to address and acknowledge that, and work with them, and build a relationship for a long time. And it's always good to engage them at an earlier stage rather than a later stage when you are just there to disseminate your finding. That's not the way. You need to engage them. You need to involve the research users from the very early stage of the inception phase of your research question. Josephine, you raised your hand. Could you please? Yeah.
Yeah, thank you, Taufik, for the excellent question, and indeed a relevant question from, I presume, a somewhat more junior researcher. Yeah, your answer is right, of course. I was thinking about a relevant project on scale up we did, which precisely points to the different roles and skills which you have to have as a health system policy researcher in engaging with politicians or policymakers in general. We did a scale up research project in which we really aimed for a national scale up in 3 different countries, one of them Cambodia, by the way. So we did engage from the project writing and throughout the 4 or 5 years the project lasted. But in the 3 different, and we made a cross-country analysis on how that engagement went. We basically used roadmaps and policy dialogues, but policy dialogues in very different formats. Not only big 50 people, visible events, but one-on-one or two-on-two conversations. And the format of such policy dialogues would very much be determined by the position you had as a researcher towards the policymaker and what you already had in terms of recognition and knowledge available. If you have your story ready, you can have a more public policy dialogue. If you're still like setting the ground and building trust, then these smaller policy dialogues are much more helpful. So there is a whole process of engagement, and you really need different skills than just the research skills. You are a networker, you're an advocate in a certain way, always based upon sound scientific research. Of course, policymakers will credit you for your scientific knowledge, not for being a politician in general. So you have to differentiate that. I think in COVID, we saw many examples of blurring that part. But being a boundary spanner, I think. And it helps if you come from, like in Cambodia, the partners we worked with from the National Institute of Public Health. They are already a natural dialogue partner with the ministry. So they had a bit of easier access, especially the senior people in the team. Whereas in Belgium, the second country, we worked with primary care physicians, which did not necessarily have access to the Minister of Health. So we really had to build that up. So it's, I think that was a long answer to how do you engage with policymakers. Sorry.
Thanks,
Thank you,
Josephine.
Josephine.
It's very, very useful answer. Thank you. It's really helpful. Anything else? Josephine, you want to add anything about, or we see a hand. Farzana, please go ahead. Oh, David. Yeah, okay, Farzana and then
Hello.
David. Yeah.
Yeah.
Hi.
I'm Munmun from Bangladesh. So thanks for the nice presentation on health policy issues. Actually, I'm also interested on these issues nowadays, and I'm planning to policy research of Bangladesh. So actually, I'm now in Yonsei University, South Korea, and my professor is also interested on it. So I'm thinking and just doing the literature research review now. So my question, I have two questions. So first question is there any standard for a country that what are the policy we should have? So I can evaluate this my country has this policy, my country has not this policy, other than the geographical some disease or some things we have. Like we have the tuberculosis issue, we have the malaria issues. So those policy we need, but is there any standard of policies list that we should have in our whole of the world, all the countries? And the next question is, when we review a policy, what extent we should expect from a policy? Like in terms of malpractice, it is written in the policy that no one should have the malpractice or doctors or quack have the malpractice, these types of issue. No one should have this. But what extent we can expect from a policy, like if a malpractice is identified in a sub-district level or rural level, who will report to whom? Is it should be also in health policy, or only the malpractice is a punishable act? So what we have to be identify when we do a review of a policy. So these two questions I have. Thank you.
Okay, so first question, I mean, standard, there is actually no standard as far as I know. It's very context specific actually. Whatever applies to Singapore may not really apply to any other country, even the neighboring country, perhaps, you know. So in my opinion, there is no standard. And that kind of leads to your second question, what we really need to look at. So there are different frameworks I mentioned. So for example, if you look at the policy triangle framework, by Lucy Gilson, you need to understand the actors that are involved and their power and position in terms of certain policy, the processes that are there, you know, and what's the other I forgot the other thing, but there are many other things. I mean, if you look at the Schiffman and Smith's framework. There are many things that you actually need to consider to understand the contextual features of a policy. And it varies from country to country, context to context, from um, the area that you are interested in. So it's very important to understand these policy frameworks, actually, I would say. I mean, I mean, you don't need to memorize all these things, but it's important to acknowledge that different people actually have done a lot of policy work. They develop the frameworks. These frameworks help you to understand what are the things that you really need to examine in the context of your country, or in the context of the disease area, or whatever you are trying to do your research on. So there is no actually straightforward answer to it that I can tell you, but what I can guide you towards is that there are different I mean, if you were interested in policy, and there is actually a methodological reader on health policy analysis by Alliance for Health Policy Systems Research that can actually help you to see. Yeah, Josephine, you want to add something? Mm-hmm, mm-hmm.
I've spoken of, it's in the chat.
Yeah, you can take a look at the response that Josephine has provided. Okay, so let's move to David.
Hi, pardon me, my voice is not very good. And hi, everybody, and greetings to you, Josephine. It's good to see you here. I'm probably going to ramble a little bit, but one thing and firstly, it was a great presentation. Obviously, I've seen some of it before, including Josephine's seminal paper. But you mentioned things like context and small groups and the difficulty of doing really policy influencing systems research. One thing I didn't hear, or a term that I didn't hear you use, was the political economy of changing health policy. And, this is obviously super important, and Jeremy Schiffman has published on this in various ways. But, for things like capitation or DRGs or task shifting, there must be a kind of a perfect way of delivering health services and financing them and having the right human resources for them and the right level of responsibilities at different levels and among different personnel. But they're obviously more or less palatable according to who's in power, whose jobs are threatened, whose income is threatened, etc. So, these issues are incredibly important, not only in designing health policy, but also in researching what works in different contexts. So it makes it very difficult. And when you think of some of the things that have gained traction, like decentralization, or the ones I mentioned before, like capitation, which is still, I guess, under review in many countries, but the fact that they've got as far as they have is pretty remarkable. So it's not really a question, but I just thought I'd throw that out there and mention it as a pretty important thing that we have to think about whenever we're designing health policy and systems research. Over.
Thanks, David. I can just answer with one word. I fully agree with you. So I kind of I didn't mention the term political economy analysis, but I mean, Lucy Gilson and Ward's framework is actually a political economy framework. It's actually known as a political economy framework. So I'm kind of alluded to it without mentioning the term itself. But you are absolutely right. It's very important. Regarding you mentioned at one point about DRG and the capitation model, that there could be a standard way of doing it, but I'm not sure whether I fully agree with that, because these standards actually shift because of the emergent behavior of the stakeholders. I mean, suppose something is a standard, you set a standard, but you still need to do research and continue to do the research, because people misuse very good things that are supposed to be there. There could be different types of cherry picking that we are not familiar with. I mean, these are the things that evolve over time, and that's why we need to have a vigilant eye on whatever is now termed or considered as a standard or a good practice. This good practice may not be a good practice in years to come. So, and yeah. So it's a complex adaptive system. Short answer.
Thanks.
You are almost at the end of our time. But if there is any other question, I'm available. You have my email address, or we can always have more sessions about it. So, is there anything else that you want to raise? If not, then yeah, okay. Yeah, Council shared some resources. Please copy that. So thank you once again. I really enjoyed talking to you. It's actually an area, as I said, very close to my heart. I'm really glad, Josephine and David, with your busy schedule, you made some time for my presentation. Really grateful for that, and also for everyone else who joined this session. Thank you so much. And let's have more discussion around health policy and systems research, which is relatively, I mean, there are many issues in the broader health policy and systems research that we really don't see being practiced in high-income countries. So I think there are many topics that are relevant to high-income countries as well. It's not really a field only specifically designed for LMICs. Of course, they're benefited. There are many areas to research because they have more challenges, but there are many issues that we need to explore from a high-income country perspective as well, and that can actually generate knowledge for the low and middle-income countries as well. With this note, I'd like to end, and again, thank you so much for your presence and inputs. Bye.